Thank you for joining us today. Our podcast entitled Hypercortisolism in 2026, Looking Past What You Thought You Knew. I'm Davida Kruger. I'm a certified nurse practitioner at Henry Ford Health in the Division of Endocrinology in Detroit, Michigan. Joining me today is Natalie Bellini. Natalie, please introduce yourself.
Hello, everyone. My name is Natalie Bellini. I'm an assistant professor of medicine at Case Western Reserve University and the program director for diabetes technology at University Hospitals here in Cleveland, Ohio.
Great. So let's talk a little bit. Let's start off with this whole concept because, I never thought about cortisol because I specialize in diabetes and it never, it really never sort of affected what I do in life. But we're thinking about this totally different. And what we've learned in a short period of time, that hypercortisolism is a serious condition. We know that it's characterized by persistent elevated levels of cortisol, the steroid hormone that is produced by the adrenal glands. We know that as excess cortisol affects nearly every organ, people with the hypercortisolism can have a wide variety of symptoms and comorbidities, including elevated glucose, hypertension, weight gain. Again, people we see every single day, bone fractures in individuals at an earlier age than we would expect. It even has psychological impacts such as depression and anxiety. People are talking to us about that all the time, and making that connection again is different for us. And then ultimately, people with these elevated cortisol levels are at a significantly increased risk of death, with mortality rates 2 to 5 times higher than in the general population. So today, when we think about it, there's an increased recognition that hypercortisolism is closely associated with diabetes, particularly type 2, that is not reaching on individuals that are not reaching their glycemic targets, or that individuals who their diabetes are difficult to control. And, we may say, oh, that person's just not taking their medication, or they're not doing what we ask them to do. But it's a serious concern for people with type 2 diabetes, and it can make achieving glucose targets more difficult by contributing to insulin resistance and increasing output of hepatic glucose. It is also linked to increased risk of cardiovascular disease and death in people with type 2 diabetes, which is why you and I are here talking about this, because it is very, very serious for people with type 2 diabetes, and it's been missed for years. So when we think of elevated cortisol, I think we tend to think of Cushing syndrome, that disease that was diagnosed or came about by Dr. Cushing in 1932. And in the past, it's a very rare disease. So again, I don't think about it. I don't do adrenals, and it's very specific. So overt symptoms of Cushing include those fatty pads between the shoulders, the buffalo hump that we look at and we think about, swollen and round faces, that moon face, abdominal weight, that central obesity, pink or purple stretch marks, skinny arms and legs, but the central obesity again with muscle wasting, thin, easily bruised skin, slowly healing wounds, acne primarily on the face. And these are often very acute onset of symptoms, but that is what we think about when we think about excess cortisol levels. We think about Cushing's. And guess what? If we continue to think that way, we're going to miss the majority of the people who have elevated cortisol levels.
I think that's really interesting because when I look back in my textbook to become a nurse practitioner, we had not enough cortisol and too much cortisol. And there are two pictures, right? And the picture of too much cortisol is the Cushing's patient, right? That person with Cushing's disease versus that person with hypercortisolism. When we see the Cushing syndrome, that person typically has had hypercortisolism sometimes for years and years and years. It has been so far non-screened, non-treated that that's what we see, right? But that's what we were taught. I was never taught to screen for hypercortisolism, that hypercortisolism could cause problems, that it increased death, that it increased cardiovascular disease, and that it might be part of the problem when I'm treating diabetes. You and I, that's what we do. And you're like, I can't get it below. I can't get this A1C below 8. They're on every magic drug. The magic drugs, the GLP-1, GIPs, none of them are working. They're not losing any weight. They're not, it's like we're putting these medications into a void instead of into a body. Those, yes. Debbie was like,
blaming,
yes.
Yeah, and we're blaming the patient.
Yes.
We are blaming
Yes.
the patient. And that's happening throughout the world, that the patients are being blamed and it's not their fault.
That's it, right? So what do we look at this comorbidities of excess cortisol? You kind of went through some of these, but we see this like increased number. What do we see? Type 2 diabetes or pre-diabetes. Hypertension is another big one, right? High cholesterol, like cholesterol that just doesn't come down like it should on some of these higher strength statins. Weight gain, even on these magic GLP, GIP drugs, we're still seeing weight gain, muscle loss, osteoporosis with some of them, serious infections, the depression. We screen for depression in diabetes clinic, but we've just said, well, lots of people get depression. Well, maybe they actually might have hypercortisolism that's helping cause, like being part of the cause of that depression, right? And then some of them even end up with memory or concentration issues. This is a lot of things that you and I have kind of, as clinicians, before realizing what we should be doing, it's just like, oh yeah, this is part of it. Note that, send them to a psychologist, but like, note this, high cholesterol, let's get them on a PCSK9, but not thinking, okay, all of these things should be making us jump to the next screening process.
Absolutely. Absolutely. And again, it's a new way of thinking about managing diabetes and other things that may be affecting type 2 diabetes that we did not learn in school. That's for sure.
So let's talk about why. What's the why behind why are we doing this now, right? What did we think about this? We're going to, Davida, do you want to talk about the Catalyst study and we'll talk about the why behind it?
Sure. Well, I think this was what was the eye opener for me and probably for, you and hundreds of other people, is the Catalyst study was published within the last year. And, those individuals who had A1Cs, 7.5 and above to 11.5, that's a pretty tight A1C to think about, 7.5. The 11.5 I can understand, but they also had to have be on at least 3 medications for their diabetes, insulin and other medications. And they had to have some micro and macrovascular complications, blood pressure medications greater than 2 medications. So complicated type 2 diabetes, complicated blood pressure. That again, how many times do you say, oh my God, I've already given that patient 2 or 3 blood pressure? That's when I send them to cardiology. I don't think about this. And so these individuals.
Yes, that's it. And we also, what else do we do? Lots of how many patients, I still have my jacket on tonight. How many patients did I see today that look like this?
Yes.
Lots of them, right? Lots of them.
So here's the head turner for me. For those individuals who had type 2 diabetes that were enrolled in the study, 24% of them had hypercortisolemia. 24% of them. This was again defined as A1C 7.5 to 11.5 with multiple standards of care therapies. So, and then if you looked at those individuals who had type 2 diabetes that was uncontrolled and were on 3 blood pressure medications, the number went up to 37%. That's not insignificant numbers. That's a lot of people who had elevated cortisol based on these standards that we are missing. And guess what? If we treat it, we get better A1Cs, better diabetes control, less insulin resistance, better blood pressure, and we decrease their risk of cardiovascular disease and cardiovascular death. So this was for me, the eye opener that I said, okay, I think I need to pay attention, because I also had some naysayers in my own office that said, oh, no. And they were looking the other way. And so when this data came out, I'm like, you got to look again, that I think we need to start screening and or take referrals from my primary care colleagues who probably are in a better situation to really do the screening. Natalie, why don't you talk a little bit about the simple test that you can use to screen these patients?
So what is the test that we do? So first of all, I think I want to take one quick second about the Catalyst study. Before the data came out, or when the data came out, we talked to a couple of the researchers, and then we said, well, what did you think the risk was going to be? And no one thought more than 5%. No one, not even the people doing the study. They were shocked that it came in at 24 and then again at 37 when it's difficult to control blood pressure, right? Think about that. The people doing the studies, the experts in hypercortisolism didn't know how, because we weren't screening for it. It's kind of like saying my blood pressure's okay because I don't check it. Right?
I don't look.
I don't look. My glucose is fine, but I don't check it and I never do an A1C. Is it fine? So even the people doing they were flabbergasted at this data.
So to put that into clinical perspective, 1/4 of all the people you're seeing, or almost 40%, because I know you have the same kind of practice as I do. Everybody has elevated blood pressure. Everyone has elevated lipids. Everyone has cardiovascular disease. Every one of my patients who has type 2 diabetes would have most likely qualified for the study because A1C is 7.5 and up.
Right. That was so, and I love that they called it difficult to control. Sometimes we get to 7.5. We're like, yay, let's go. But guess what? It's not really good enough, is it? The ADA says less than 7. And we all kind of go, oh, but it was 9. So now it's 7.5. That's not enough. Right. So when we look at that and have to put them on 3 and 4 medications to get there, and they're on insulin and they're doing this and they're taking these, once weekly, very strong medications, and we're still not able to get them to goal, there should be a bell going off in your head. Like your body's fighting it with this extra cortisol. That's what's happening. The cortisol and the glucose and they just don't play in the sandbox. That insulin, cortisol, they're all in that blood together, and the cortisol is not allowing things to work the way they're supposed to.
Well, the other thing is I always say to my patients and sincerely believe that their greatest risk in life is going to be cardiovascular disease.
Yes.
And then if I'm missing this,
right,
they are set up for cardiovascular risk, cardiovascular disease, cardiovascular death, because I didn't do a simple test that could give us all an answer that could change their outcome for life.
That's it. And how easy is this test? So what we do is we do a 1 milligram overnight dexamethasone suppression test, or DST. So what the person does is they take a milligram of dexamethasone before they go to bed at 11 o'clock at night and go to bed. They wake up in the morning and they go straight to the lab and get a fasting cortisol with a dexamethasone level, because we want to make sure that they're not processing the dexamethasone too quickly, and we want to make sure they took it, right? Those are the two things. So, and what we look at is that it is recommended as first-line screening, number one. It is the screening we do now. We used to do swabs. We used to do all these other things. Stop. Do the overnight. It's the most consistent test we can do, right? And the sensitivity is up to 95%. And then we use the cutoff of greater than 1.8. So that's what we're looking for. So what we want is we want that number to be suppressed. I say to people, I want your number to be 0.2, right? We want this to be red is what I tell them, right? We want this to be red. We want this to be low. If it's high, then we know there's a problem.
Absolutely. And that's really when you start thinking about a referral. There's a lot of things that go in post elevated levels, but we can't get into that today, because what we want to talk about is primary care. Our colleagues need to be screening because they see the majority of the patients who have type 2 diabetes. The test is very simple. Just write the lab, give them the medication, and write the prescription, go in first thing in the morning, have it done. And if it's elevated, that's when you want to call in your colleagues from endocrinology and have a nice partnership to see what next steps are for this particular patient.
Yeah, it shouldn't be difficult. Now, some of the endocrinologists we work with have asked primary care to wait 4 weeks and draw a second level, so that they're, in endocrinology, we always repeat labs.
Absolutely.
So when we work with our primary care partners, the majority of us are saying, okay, just like if you had a high TSH one time, I don't start levothyroxine.
No,
I don't,
no.
right? Because they could have a cold in their thyroid, just like they, can get a cold in their nose, and that TSH goes up and then it goes down a few weeks later and everyone's in a panic and now they're on medicine, right? We want to repeat the test in about 4 weeks. Again, 1 milligram of dexamethasone at 11 o'clock at night. You then order so that's a pill that you're sending to their regular pharmacy, 1 pill. They get up in the morning, they go to the lab, they get a fasting cortisol level, right? And they get a dexamethasone level. And we look at those 2 numbers together. We use Epic in our hospital system. So what we've told people is, if you screen and send us the results, just open the chart and say, hey, can you look at these? We will help you make the next decision even before you order a consult. So that way, so we're doing both. We're doing either redraw it 4 weeks later, or just send us a message and we can help you right away and tell you what to do next. But the screening itself is so important, because when we finally find people that do have hypercortisolism and we treat it, these people are on less medications. They feel better. A lot of them start losing weight right away. They're feel better and less depressed. And then we say things like, we are so sorry that for the last handful of years, we've made you feel like you're not going to, they're just like, oh yeah, this is Mr. Jones and he can't get to goal and his blood pressure is always high and wait a minute. He's got something else going on in his body that is causing all of this. So there's this sense of relief when we do, and we can say, now we can look at the source and figure out what to do for the next steps for treatment.
And I feel like if it weren't for the Catalyst study, we wouldn't be having this conversation.
Right.
And so if you've not read the Catalyst study, take a moment and take a look at it. It's not complicated to understand. It's very straightforward. And I think your resolve about screening will be the same as Natalie and mine, in that, this is a simple test. This is important, and the patient deserves it for a potential better outcome. And I love what you said, and I'm going to bring it back to my clinic, in that if our primary care colleagues would be so kind as to do the screening, because they have them there, I'll go look at the results and help guide you. I'd be happy to do that. And I agree with you. Doing a second for some, I think that makes a whole lot of sense, because patients they don't want to jump into a new diagnosis if it's not there. So absolutely, no reason you can't, making sure the patient doesn't get lost to follow up. But I love that thought. I love that.
So let's summarize this. Number 1, Cushing syndrome is very rare. The syndrome of Cushing's is rare. It is rare. It was in your textbook as rare. It is rare. But elevated hypercortisolism is not rare. It happens in 24% of difficult to treat. That's A1C of 7.5 up to 11 people with diabetes, as well as 37% of those with difficult to treat. Remember, 7.5 to 11 with more than 2 hypertensive medications, which was probably, if you went to your clinic notes today, a third or half of your patients, because we're seeing the sickest of the sick in endocrinology. In primary care, this is where we are, right? You may be sitting at anywhere from 10 to 30%, depending on your population in your own office.
Right. And then elevated cortisol levels increase the risk of cardiovascular complications. Our patients are already at risk of that. Why are we going to increase it? And other comorbids, and interferes with the quality of that patient's life. You said it. The depression goes away. They have an improved outlook on life. And some of that is directly related to exactly what we're talking about, the elevated cortisol. And then screening is, I can't say it enough, is relatively simple and should be considered for those individuals with difficult to control type 2 diabetes and difficult to control hypertension. Please consider screening your patients. The simple test, the outcome for your patients is just huge. Thank you.
Thank you all for joining us today.